Have you ever wondered about the common misconceptions surrounding epilepsy and seizures? Let's clear the air. A prevalent myth is that epilepsy is a mental illness, when in fact it is a neurological condition affecting the brain's normal electrical activity. Another common fallacy is that all seizures are the same. The truth is that seizures vary greatly, from minor absence seizures, which might appear as a brief moment of inattention, to more severe tonic-clonic seizures, which involve full-body convulsions. There's also a widespread belief that epilepsy is contagious. This is simply not true. Epilepsy is not an infectious disease and cannot be transmitted from person to person. Lastly, some people think that you should restrain someone having a seizure or put something in their mouth. This is dangerous and can cause injury. The best thing to do is keep them safe from harm until the seizure ends. Now that we've debunked some myths, let's delve into the history of epilepsy treatment. Epilepsy treatment has a rich history dating back to the mid-1800s. The first instance of a documented treatment for epilepsy traces back to 1857, when Sir Charles Locock, Queen Victoria's personal physician, introduced potassium bromide or K-bromide as a remedy. This was after he observed that women with hysterical epilepsy, a term used at the time, experienced fewer seizures during pregnancy. He attributed this to the sedating effect of the increased bromide levels in their bodies. K-bromide, an inorganic compound with sedative properties, was then believed to suppress the nerve activity responsible for seizures. It was initially well received due to its effectiveness in reducing seizure frequency. This made it a popular treatment and marked a significant milestone in the history of epilepsy treatment. However, over time it became clear that K-bromide was not without its drawbacks. The long-term usage led to an array of side effects, including impairments in speech, memory, and movement, along with skin rashes and mental confusion. This led to its decline in popularity by the mid-20th century. Yet the use of K-bromide laid the foundation for future epilepsy treatments. It demonstrated that chemical compounds could indeed alter brain activity and potentially control seizures. This discovery sparked a wave of research into finding more effective and safer compounds for epilepsy treatment. In the years that followed, other anti-epileptic drugs were introduced. Phenobarbital, for instance, became widely used in the early 20th century. It was followed by the likes of Dilantin in the 1930s and Tegretol in the 1960s. Each new discovery brought with it hope, and over time these drugs became more refined and targeted, offering better control of seizures with fewer side effects. Fast forward to the current day, and we have a myriad of anti-epileptic drugs available, each with specific targets and mechanisms of action. The journey from K-bromide to the modern-day anti-epileptic drugs has been long and full of trials and tribulations. From K-bromide to modern anti-epileptic drugs, the journey of epilepsy treatment has been a long one. But what about today? Today, epilepsy is the fourth most common neurological disorder in the US. In the current landscape of epilepsy treatment, age is a significant risk factor, with children and older adults being most susceptible. Mortality rates are higher among those with epilepsy, often due to accidents that occur during seizures, underlying health conditions, or sudden unexpected death in epilepsy. Now let's talk about causes and triggers. Epilepsy can be caused by various factors including genetic influence, brain conditions, infectious diseases, prenatal injury, and developmental disorders. Triggers for seizures differ from person to person, but common ones include lack of sleep, illness or fever, stress, bright lights, caffeine, alcohol, or drugs. Speaking of drugs, there are several that can lower the seizure threshold and increase the risk of seizures. These include certain antidepressants like tricyclic antidepressants, venlafaxine, and duloxetine, as well as bupropion. Illicit drugs like cocaine, benzodiazepines, and tramadol also pose a risk. Certain antipsychotics like clozapine and chlorpromazine, mood stabilizers, antimicrobials, stimulants, hormonal agents, cardiac drugs, and anesthetics like ketamine and propofol can also increase seizure susceptibility. However, it's not all doom and gloom. The past few decades have seen significant advances in epilepsy treatment. We now have more than 20 types of anti-epileptic drugs, many of which have been introduced in the last 15 years. These drugs are selected based on the type of seizure, the age, lifestyle, and overall health of the patient, and other medications the patient may be taking. For some patients, surgery, nerve stimulation therapies, dietary therapies, or even medical marijuana may be considered. Still, it's important to remember that while these treatments can control seizures, they do not cure epilepsy. Each person's journey with epilepsy is unique, and it can take time to find the right treatment or combination of treatments that will help control seizures without causing debilitating side effects. Despite these treatment options, epilepsy remains a complex disorder, with various types of seizures to consider. As we move forward, continued research and understanding are key to improving the lives of those affected by epilepsy. Seizures, the hallmark symptom of epilepsy, come in many forms. To understand the complexity of epilepsy, it's essential to comprehend the different types of seizures and their characteristics. Let's start with focal seizures, which account for about 60% of all seizures. These seizures originate in one specific area of the brain. Focal seizures are further divided into three categories. First, we have focal aware seizures, previously known as simple partial seizures. In these instances, the person remains conscious and aware throughout the episode. Next, we have focal impaired awareness seizures, formerly known as complex partial seizures. Here, the person's consciousness is impaired or lost during the seizure. Lastly, we have focal to bilateral seizures, where a focal seizure spreads to involve both sides of the brain, leading to a loss of consciousness. Moving on to generalized seizures, these account for about 30% of seizures. These seizures involve both sides of the brain from the onset. They are further divided into motor and non-motor seizures. Motor seizures include episodes like tonic-clonic or epileptic spasms, while non-motor seizures encompass incidents like absence seizures, also known as petit mal seizures, which involve a brief loss of consciousness without any motor symptoms. Finally, we have the unclassified epileptic seizures, which make up the remaining 20%. These seizures cannot be classified as either focal or generalized due to insufficient information. It's worth noting that the classification of seizures has evolved over time. For instance, the terms we use today, like focal and generalized seizures, are from the revised seizure classification of 2017, which replaced the previous terminology from 1989. The classification is based on three key features to consider: the origin of the seizure in the brain, the degree of awareness during the seizure, and the level of bodily movements during the seizure. In conclusion, understanding the type of seizure a person experiences is crucial to managing epilepsy effectively. Recognizing these different seizure types enables us to tailor treatment strategies, provide appropriate care, and ultimately, enhance the quality of life for those living with epilepsy. Seizure symptoms can be both motor and non-motor. This distinction is crucial as it aids in understanding the wide range of ways that seizures can manifest in individuals. Let's start with motor symptoms, which involve changes in muscle activity. Automatism seizures are one example. These seizures cause involuntary, often repetitive movements that may seem purposeful, but are not under the person's control. This can include actions such as lip smacking, chewing, or hand rubbing. Another type of motor seizure is the atonic seizure. Atonic or drop seizures result in a sudden loss of muscle tone, causing the individual to fall to the ground. This can be particularly dangerous depending on where the person is when the seizure occurs. Tonic seizures, on the contrary, cause the muscles to stiffen suddenly. This rigidity can affect the entire body or be limited to certain parts, such as the arms, legs, or trunk. We also have epileptic spasms, which are characterized by sudden flexion or extension of the arms, legs, or head, usually occurring in clusters. Lastly, in this category, we have clonic and myoclonic seizures. Clonic seizures involve rhythmic jerking movements, while myoclonic seizures result in quick, sudden jerks of a muscle or group of muscles. The jerk in a myoclonic seizure is often described as an electric shock and can be quite startling. Switching gears, we also have non-motor symptoms. These are changes in sensation, emotions, or consciousness without any physical movement. These can include feelings of fear or anxiety, changes in vision or hearing, or even loss of consciousness. Understanding these various symptoms is key to recognizing when a seizure is happening. It's also important to note that seizures can present differently in different individuals. Some may only experience non-motor symptoms, while others may have a combination of both motor and non-motor symptoms. Recognizing these symptoms can lead to a timely and accurate diagnosis, which is the first step towards effective treatment. So, being aware of these signs can be a literal lifesaver both for those experiencing seizures and those around them. Let's summarize what we've learned about epilepsy and seizures. We've debunked common misconceptions, highlighting that epilepsy is not synonymous with seizures, but rather is a neurological disorder characterized by recurrent seizures. We've journeyed through the history of epilepsy treatment from the use of potassium bromide in the mid-19th century to the array of anti-epileptic drugs available today. We've explored the different classifications of seizures, understanding that they can originate from different parts of the brain and affect awareness and body movements to varying degrees. We've learned that focal seizures, making up 60% of cases, can be either aware or impaired, and can sometimes generalize across the brain. We've also looked at the array of symptoms that can accompany seizures, from motor symptoms like spasms and clonic movements to non-motor symptoms such as changes in sensory perception or behavior. Understanding epilepsy and seizures is the first step towards promoting awareness and improving treatment options for those affected by this neurological disorder.